I'm your moderator, Dr. Daniel Olenga, and we shall be dissecting a patient who occasionally gets confused. With us in the panel from Makerere University in his year 4 of the Bachelor's of Medicine and Surgery, our case presenter is Buire Silas, and the pre-hospital presenter will also training school. And the expert for this session will be Dr. Baluka Koni. She's an emergency physician with City Ambulance Uganda. I'm glad to welcome all of you to this great session. Please, let's start the session. Deborah? Where you can unmute and start. There is no. Okay, yes, here comes
Hello.
Deborah. Yes.
Good evening to you all. Deborah is my name, and an EMT dispatched from an ambulance station. I've received a call from a peripheral clinic to pick up a 33-year-old male that is presenting with episodes of confusion, headache, and dyspnea. So before I leave the ambulance station, we shall be using a type B ambulance, the basic life support ambulance, and we shall be a team of 2 people, 1 EMT and an emergency driver. And we are going to have the following equipment according to the situation as described from the clinic. We shall have our PPEs, oxygen, nasal prongs, the different diagnostic equipment, IV access that involves the cannulas, few, and IV fluids, and some medications, as well as a stretcher to lift a patient. And on arrival to our referral facility, Deborah is my name, and I've picked a 33-year-old male patient from a peripheral clinic. He's presenting with episodes of confusion, headache, dyspnea that he has reportedly had for 1 day, and an electrocution burns. He has visible burns around the scalp, neck, and the right hand. According to the sampler that's collected, this patient has not had any known illnesses. He has not been managed. He doesn't have any past medical history, or he's not on any medication, no known allergies. We don't have any known illnesses. According to my assessment, he has a patent airway, very conscious. However, he has a mild respiratory distress. His respiratory rate is 27 breaths per minute, and we've managed to correct SpO2. He's saturating at 96% via 5 liters of oxygen by the nasal prongs. Our heart rate is 112 beats per minute with a blood pressure of 110/78 mm per mercury. Capillary refill is less than 2 seconds. and I've managed to we've managed to maintain our airway. We're still giving oxygen. I've given some paracetamol, some IV paracetamol to help with the headache. The wounds were already dressed from the clinic, and I would highly recommend a continuous reassessment. We do an ECG and some few blood tests to rule out any damages to the internal organs, and as well as a psychological consult due to the confusion that we've been having. Handing over to you, Dr. Wade.
Okay, thank you so much, Deborah. So we received a 33-year-old male. 33-year-old male has been stated earlier on. So in our primary survey, the air was patent, the patient was alert and speaking, and the breathing, they had a mild tachypnea with 27 breaths per minute, and they were saturating at 90% on room A. In the saturation, we had the extremities were warm with a cup refill of less than 2 seconds. Our pulse rate was 116 beats per minute. That is a tachycardia. The pulse was regular with full volume, and the BPs were 110/78 with a map of 88 millimeters of mercury. So in the disability, the patient had a GCS of 15/15. However, with occasional episodes of confusion, the pupils were equal and reactive to light, measuring 4 millimeters, both of them. However, the patient had reduced movement of the lower limbs as compared to the upper limbs. In our exposure, the patient had superficial, partial thickness, and deep partial thickness bands that were on the scalp, the neck, chest, and the right hand, covering around 21% of total body surface area.
So please, there is a poll running, and the question is, which emergent condition should be prioritized in this patient? So please just tap your screen, click answer, let the answers keep coming in. Part A, acute ischemic stroke. Part B, cervical spine cord injury with impending respiratory compromise. C, acute bacterial meningitis. And D, pulmonary embolism. I like the numbers of people so far attempting. You still have a couple of seconds, please. Let's have all of you attempt this. Tap, tap, tap. Okay. Tapping through. All right. Just have 15 seconds to go, then we shall carry on. So most of you are actually answering, which is lovely. Okay. Perfect. So we can end the poll now and carry on with so those are the results. We had part B as greatest answer of choice. So thank you very much. Let's carry on, Breeder.
Okay, next slide, please.
Do we have any comments from the audience? Remember to engage with the chat. We have Dr. Anna on chat who will be able to respond to all your queries. So please keep them coming. We are following them closely. And at this point, I would love to invite our expert, Dr. Connie. What are your initial thoughts following the pre-hospital that handed over the patient to the in-hospital team, which did the primary survey, and now the sample history as well has been presented? What are your initial thoughts, and what is your preparation and approach to this patient? Dr. Connie.
Thank you, Dr. Daniel. So my initial thoughts, we have a 33-year-old male. The call came in, and the EMT picked a patient with a history of being electrocuted. This patient has partial thickness burns around the chest, around his neck. His dyspneic gets episodes of confusion. And we've seen on our examination, he actually has reduced motor in his lower limbs. So my quick assessment, I'm going to think about a compression in this patient. He's been electrocuted, and a compartment syndrome, especially coming from the chest, that is giving us the dyspnea, is going to be my first thought. And then I'm also quickly thinking an electrolyte imbalance. And then, where was this patient? Was this gentleman on a pole? Maybe he was a UEDCL worker and was electrocuted while he was up there on a pole and came down and fell. Could we be having cervical spine injury? So right from the time I get this patient as an EMT, I really want to secure this guy's cervical spine, especially if I have any history that he may be a worker. But also remember, sometimes when you're electrocuted, you actually are thrown away from the source of electrocution right away. So we are thinking a cervical spine just from our primary survey. We are thinking of a cervical spine. We are thinking of a compartment syndrome. So in this patient, I really want their cervical spine protected first. And then I want us to look at the compartment syndrome bit. What will I prepare, and how will I approach this patient? Definitely at pre-hospital, like I had earlier said, we have his age. He's 33. He's a male. Likely he was drinking. We don't know that history, but given the fact that he's 33, he's a young man. Chances are he may have had an intoxication. So I want to keep a suction machine or a suction catheter. I want to keep things that are going to make sure my airway is open as much as possible, just in case this patient tips off from being actually alert and conscious to being in a stuporous condition. So I want to make sure I have things that are going to protect his airway. I have an oropharyngeal airway in my bag. I have a Goodell. I have a suction present. And then I need to communicate to the person coming that, okay, this is the patient I'm bringing in. And I suspect they may have intoxicated, or they may have used some alcohol, and probably that could have contributed to the electrocution. And then I need to protect their cervical spine by all means, because this is trauma. And then I need to have large bore cannulas and give IV fluids. So you realize that this young man's heart rate was really quite high, 112 beats per minute. That's quite high for a 33-year-old male. So pain alone in a 33-year-old, I do not think they could give us such a high heart rate. So I start thinking shock. Yes, the blood pressure looks normal. However, they are tachycardic. They could be still compensating. So I need a large bore cannula, either 2 of them or the biggest I can have, an 18 or a 16 on me, and actually IV fluids. Preferably, I would love to have normal saline with me, and I would particularly start there. Thank you, Daniel. Oh,
Great.
perhaps something that I forgot. In our disability, we didn't look at this gentleman's random blood sugar, probably hypoglycemia. In Uganda, currently, people are having only 1 meal. Could the hypoglycemia be contributing to our episodes of confusion? So it would have been a great opportunity for us to have a random blood sugar for him. Thank you, Daniel.
A great, Dr. Connie. Thank you very much. And what I gather from you here is that you had the primary insult directly from the electrocution, but also there could be secondary insults, especially if the patient is potentially thrown away from the source of the index injury. Great. And you've given us beautiful thoughts on how you'd approach this patient, and you've addressed all the systems from A up to E in preparation and anticipation for how you're going to manage this patient. Let's carry on to the next slide.
Okay, so in the sample history that we managed to obtain, in the signs and symptoms, we had occasional episodes of confusion. The patient also had severe headache and anterograde amnesia of the events that were surrounding the electrocution. There was progressively worsening difficulty in breathing. The patient was restless, and then they had burns on the scalp, neck, and the right hand, and then the chest. So allergies, there were no known allergies to us, and then there were no known medication. The patient wasn't on any medications. The past medical history, there were no known chronic illnesses like hypertension, diabetes. The serum status of the patient was unknown. The last oral intake was not known to us. Then the events leading to the presentation, the patient was electrocuted 2 hours before admission while on an electric pole for routine work. He is an electrician who works with the UEDCL, so he was on the electric pole. He immediately lost consciousness, but he regained it after approximately 5 minutes and sustained burns on the face, neck, and the right hand that came into contact with a wire. So this was our ED intervention after our primary survey. The airway, we managed to put a cervical collar since we are suspecting a C-spine injury. In the breathing, we put the patient on oxygen via nasal prongs, 5 liters. And then we continuously monitored the SpO2 to see whether the patient was desaturating or improving. So in the saturation, we put 18 gauge cannula, and then we started IV fluids. We gave IV fluids using the Parkland formulas. I had told you the patient had around 21% total body surface area of burns. So we gave Ringer's lactate, starting with 1 liter start, then 1,490 mils over 8 hours. Then we gave the remaining fluids over the next 16 hours. We monitored the patient. We monitored the patient's urine output using a urinary catheter, since the patient was at risk of kidney injury. So in the disability, there was none. Then the exposure, we applied BioCure, which is a cream on the burns, then the dressings of the wounds with gauze. So as we continue in the secondary survey, so we did a head-to-toe assessment or a brief examination. So in the head, there were superficial, partial thickness bands on the face and the scalp. In the neck, there were bands on the right side of the neck. The trachea was central, no midline cervical tenderness, and there was no jugular venous distension. So in the chest, we had bands on the right side of the chest. However, there was equal air entry bilaterally. The abdomen was grossly normal. Extremities were warm, cup refill of 2 seconds. The burn wounds on the right hand. However, the left hand was okay. Then neurological exam, we had a GCS of 15/15, however, with reduced movement of the lower limbs versus the upper limbs, which worsened with the course of hospital stay. In the skin, right-sided superficial and deep partial thickness burns on the face, neck, chest, and arms, covering around 21% of total body surface area. So next slide.
So great. Thank you very much, Silas. Dr. Connie?
Thank you, Silas. Actually, the team quickly realized that this is a trauma patient, a burn patient, and I like the fact that even after we had forgotten about the sequela pre-hospital, we remembered it in at the ED. So, like Silas has ably put, this patient is a burns patient. And we are going to take that his burns were from a high voltage. We are just lucky that he's still alive, because if it was up an electric pole, most likely that was high voltage. 2, I also want us at this point to think of from the primary survey till now, I want us to think about a patient with a potential neurogenic shock. We have to have it at the back of our mind, and even if it's not very evident, we are still looking at the burns because they are going to kill this gentleman a lot faster. But I want us to also think about the neurogenic shock, because the burns might mask the neurogenic shock, and then you only concentrate on the burns and forget the other aspect. And you realize that you're resuscitating a patient who is not picking up, but then there is another cause. So 1, I want us to know how high was the voltage. Is this patient having compartment syndrome at this point? Because we know in burns that are affecting the chest, the abdomen, the thighs, sometimes most times what kills these patients is actually compartment syndrome. So at the back of our mind, as we are working through, I want us to think about compartment syndrome. How does a patient with compartment syndrome present? Because regardless of how well you secure your patient's airway, you give them oxygen. But if you're not dealing with the compartment syndrome in the chest, you will lose the battle to shock. So to obstructive shock, actually. So as we are looking at patients with burns, especially those that are involving the chest, at the back of our minds, we should start thinking about compartment syndrome as one of those complications, early complications. And then during the secondary survey, I would want us to look for any exit wounds. We strip our patient naked. Sometimes we may see only the superficial, the hand, the face, the neck. If we don't take away the trousers, it may be difficult for you to actually see that there are other burns, there are other fractures or other injuries. So we literally briefly strip our patients naked and do a thorough head to toe. Do a log roll and look at the back. Are there any wounds? Are there any spinal injuries that may have been missed during the primary survey? So I would have loved to hear that we log rolled the patient one more time, looked at their back, made sure they didn't have any spine injuries, because it's also very important to note them. Made sure that on the lower limbs, we didn't have any fractures, any subtle injuries, because that's exactly what the secondary survey is about. But all in all, Silas and the team actually handled the patient well. They realized that this patient is severely unwell, and decided to go for the Parkland formula, which we all know is meant to guide you on how much fluid you should be giving your patient in the first 24 hours. This is basically aimed at you not under resuscitating your patient. You may look at a small person and you forget that the degree of, or the total burn surface area gives you a bigger picture, and you under resuscitate this patient. So the Parkland formula is very vital, but it's only useful in the first 24 hours. After 24 hours, it's usually less useful, because we assume that your patient has actually compensated, has pulled water elsewhere. So if you follow the Parkland formula, chances are you're going to over-rehydrate this patient, and you're going to cause them things like pulmonary edema, heart failure. So yes, I am happy that we used the Parkland formula. Thank you. Thank you, Daniel.
Very much, Dr. Connie. And so we move on to our second poll of the night. Which bedside investigation is most important immediately in this patient? So let's pull up the poll, and once it's on your screen, please tap as fast as you can. Let's get on. So the question is, which bedside investigation is most important immediately after the primary survey in this patient? Part A, EEG. Part B, pulmonary function test. C, barium swallow study. D, a 12-lead ECG. Right, we have a couple of seconds to go. I encourage all of you to continue tapping, and yes, tap the right answer, please. It's the most important thing as well. Okay, so 15 seconds to go. Part A is EEG. Part B, pulmonary function test. C, barium swallow. And D, a 12-lead ECG. Right? A couple of you have really thrown through your answers. So we can end the poll at this point. And okay. So the best result, or the best option, was a 12-lead ECG, which was part D. So let's carry on to the differential list.
Thank you very much. So from our primary survey and the secondary survey and the sample history that we gathered, we came up with differentials. The first differential was electrical burns with deep tissue injury in view of the superficial and deep partial thickness burns that were on the scalp, the neck, the chest, and the arm. We also had a differential of the cervical spine injury, which was in view of the lower limb weakness. Then, and also the history of electrocution. We also had the differential of a mild traumatic brain injury, which was in view of the headaches and the episodes of confusion in the patient. We had also a differential of a respiratory failure in view of the difficulty in breathing and the possible C-spine injury. We also had a differential of cardiac arrhythmia in view of the tachycardia in this patient and the history of being electrocuted. Next slide. So from that, we did some investigations. From the blood samples, we did the CBC. However, I'll just talk about the positives that were in the CBC. There was a slightly elevated white blood cell count, as you can see. Then there was also a slightly elevated neutrophil count, neutrophilia in this patient. However, the hemoglobin was normal. So the neutrophilia and the white blood cell count, maybe we thought because the patient was having burns, so it could have been an active inflammatory process, which was slightly elevating the white blood cell count and then the neutrophils. So in the biochemistry, we had an elevated AST. However, our electrolytes, sodium, potassium chloride, were all normal. The creatinine was also normal. However, the urea was decreased, and then the urea creatinine ratio was decreased, which was pointing us maybe to a possible kidney injury in this patient. So in the imaging, we did an ECG, which showed a sinus tachycardia with 110 beats per minute. However, there were no other observable changes, no arrhythmias recorded on the ECG. Also, the MRI was done in view of the lower limb weakness and the suspected C-spine. So in the MRI, imaging of the cervical spine demonstrated changes suggestive of edema from C3 to T2 with an intact spinal cord. They did a repeat MRI after like 8 days, and there was interval development of cord swelling and acute ischemic infarction.
And so following the differential list and the index investigations that we have received, we move on to poll 3, which is popping up on your screen shortly. And it goes, despite initial stabilization, you can start answering it. The patient develops worsening lower limb weakness. Repeat MRI demonstrates spinal cord swelling with acute ischemic infarction. Which diagnosis best explains this deterioration? So 1, GBS, 2, acute transverse myelitis following a viral infection. We have the delayed spinal cord secondary to electrical trauma, and then lumbar disc prolapse. You can tap as fast as you can when you see the right answer, and we shall give you the correct answer in due course. Right, so we have 15 seconds to go. I encourage all of you to answer. We said in adult education, all answers are mostly correct. We only modify them. So just tap, of course, logically as well. Right? So I will end the poll here. And most appropriate answer was C, delayed spinal cord injury secondary to electrical trauma. And so, Dr. Connie, over to you. From the brief examination and investigations, what are your differentials at this point, and what would be your management plan?
So at this point, from the presentation of the patient, I definitely have electrical burns with a possible compartment syndrome as one of my differentials. I also have a cervical spine injury and a spine injury resulting from the electrocution. But also remember, this gentleman was working from way above on a pole. So it's possible that it's not only the cervical spine that is actually injured. We may have the lumbar, sacral, anywhere along the spine. So I'll keep it at a spinal injury. And the increased tachypnea and dependence on oxygen, I would leave it at cervical spine injury affecting our respiration plus the compartment syndrome. What's my management plan? Of course, definitely we are going to start with the ABCDE, the airway. This is a patient who was occasionally getting confused. At that moment, I want to keep on his bedside anything that can protect his airway. This is a patient who likely would tip off from 15 as the GCS to somewhere less than 12 at any point. So this is a patient whose airway protection equipment I should have on the bedside. Just in case we tip off to a reduced GCS, I should be able to protect their airway. This is a patient who is also likely to develop seizures. So I want to make sure around his bedside, we do not have things that are going to worsen or cause injury to him, just in case he actually starts convulsing. And then I want to still keep this patient on oxygen, depending on how he's responding to the 6 liters. I want to maintain him not more than an SpO2 of not more than 96%, and I don't want him to go to an SpO2 of less than 92. So I need to make sure I have this patient's oxygen levels well in control, because he had a brief session of loss of consciousness. So we definitely had a mild TBI ongoing. So we need to keep this brain well oxygenated. And then the electrical shock or the burn or the current didn't just go through his hand, his neck. It most likely went through his brain, went through his entire body. So I want to keep an appropriate oxygen level. I'm going to leave this patient on oxygen. Titrate between 1 liter to 6 liters, depending on what gives you at least 96% as the maximum. I do not want to go to 95, 99, to 99 and 100, because then I'm giving too much oxygen. When we get a chance, we can go and read about the effects of excessive oxygen to the brain. That's why there is that range. I know when we are treating some patients of ours, we want to see them at 99, at 100 while on oxygen. So I want to tightly range it between a 93 to a 96 as the range. When we come down to the circulation, I want this patient to have a cup refill time that is less than 2 seconds. I want them to be warm, okay? Not hypothermic. I want them to be warm. Their peripheries to be warm. Because of the burns, because of the loss, 21% is quite a large surface. Because of loss of that protective layer, this patient is losing fluid through that open, I don't want to use the word skin, but through that open wound, they are losing fluid. So after us doing the Parkland formula, which gives us a chance to use it for over 24 hours, we are going to maintain this patient. If our patient can feed orally, it would be best we get fluids into them orally, because the chances of having a pulmonary edema, cardiac failure are really low. Especially for patients who are elderly in nature. Remember, even when you're at home, you can get an electrocution. But for this young man, of course, his kidneys are still well, unless they've been affected by rhabdomyolysis. So I want to make sure I have a normal blood pressure and a normal heart rate. Now, at this point, I want an ECG to make sure we don't have an arrhythmia. We can do an initial ECG, but we need to repeat one at 12 hours, between 6 to 12 hours, because initially, if the current was really not so much, we shall get a sinus tachycardia, like this gentleman got. It's a normal rhythm, but tachycardic, which with resuscitation, pain management, keeping the patient warm, we shall get it back to normal. However, we can get the serious arrhythmias like the VFibs, which the assistors, which actually are going to kill our patient. So if you have you need to have an initial ECG, what we are going to use as our baseline. Where are we starting from? And then we need to do one at 6 hours and at 12 hours to check, have we had any changes in this gentleman's ECG? Is the damage progressing, or we've got at a helm of it? In the disability, this is a patient whose GCS we should routinely look at. The GCS is going to help us just to make sure we are not worsening in brain function. Remember, you can have a spine injury with a fully awake mind, with a patient who is fully conscious. But then if your patient starts reducing in GCS, you start thinking, do we need a brain CT? Actually, as one of our investigations, given the fact that this gentleman fell from a height, we were meant to do a brain CT just to rule out any hemorrhage. Then you also want to make sure this patient is not hypoglycemic, neither are they hyperglycemic, because hypoglycemia will kill your patient a lot faster than the electric shock or than the dehydration. So we need to make sure our patients' random blood sugars are within normal ranges. That's between 3 to around 7.0 millimoles per liter. And then most importantly, this patient needs to be kept warm. They've lost part of their protective apparatus. They are losing water heat rapidly, more than the rest of the patients. So if you have an aluminum blanket, it would be very nice because it does not stick on the patient. On the wound, we wrap them up just to make sure they stay normothermic. And then, of course, at this point, we need the orthopedic team to come in, or plastics team to come in, especially if you're thinking about compartment syndrome, because compartment syndrome is not only going to give you obstructive shock, but it's also going to give you rhabdomyolysis. Rhabdomyolysis is not good for your kidneys, it's not good for your brain, it's not good for your heart. So you need, one, to do an sclerotomy as soon as possible to open up the compartment, but also you need to watch their urine output. So in most patients, we are going to look at a normal of 0.5 mils per kg per hour. But then in burns, especially with high superficial, with a high total body surface area, you want to aim at a higher urine output compared to the usual patient. So you may go up to 7 mils per liter per kg per hour. And this also, how much urine your patient is making is going to determine how much fluid you're actually going to give the patient after the initial boluses of the first 24 hours. Your urine output is going to guide how well your patient's kidneys are actually functioning. You do not want your patient to recover, the wounds recover, you get them out of the shock, but then they stay with a chronic kidney injury that came from much earlier. Two, I would need the orthopedic, the orthopedic team on board to look at the spine. Is there anything we are going to do? But this is a patient we want to nurse in a supine position, protect the entire length of the spine because he came from a height. Chances are even another portion of his spine is actually injured or has some sort of edema going on. So you need to have them stabilized, like the entire spine stabilized, right from pre-hospital through the ED and up to the disposition end. So where do I want to dispose this patient off? I definitely want to dispose my patient off to ICU under the care of the orthopedic team. Why am I choosing ICU or HDU and not any other patient? Electrical burns are usually high degree burns. These patients are usually very complicated. Their kidneys are at a very high chance of failing. So you want them at a place where they can be ably monitored at least every 1 or 2 hours. Their vitals looked at, their progression of levels of consciousness, progression of the spine injury. You need that assessment at least every time possible, which we cannot have on a general ward. So basically, I would want my patient admitted to the ICU, and then someone is going to ask me, do we need to do antibiotic prophylaxis? In Uganda, I will say yes, we shall need to do, because you and I will agree. In Uganda, if you're picked from an accident site or a trauma site, whatever they've covered you with is either a cloth that has been picked from somewhere. We don't know if it has been contaminated or not. So this is a patient for whom I'd love to give an antibiotic cover, given the environment we are in. I think that's what I had. Thank you so much, Daniel, and the entire team.
Thank you very much, Dr. Connie, for those elaborate insights that you have really dissected. I couldn't add anything else to your voice. Fast forward, let's move on to the working diagnosis and bring this case to a fruitful end. Bwire.
Thank you so much, Dr. Connie. So from the history we've gathered and the examination that we did, we came up with a working diagnosis of superficial and deep partial thickness electrical burns with deep tissue injury. And then we also had a working diagnosis of cervical spine injury. Next slide. So our management plan, according to what we had gathered, so the patient was put on oxygen, 5 liters via nasal prongs, as the oxygen saturation initially was low. So we put them on 5 liters. We gave IV paracetamol, 1 gram TDS for pain management in the patient. We gave IV ceftriaxone, 2 grams once OD. 2 grams OD. This was for prophylaxis. As Doctor had talked earlier on, we are not sure the circumstances so we gave it as prophylaxis. So we gave ceftriaxone here. Then we gave IV fluids, Ringer's lactate in this case, 4,430 mils, according to the Parkland formula in the first 24 hours. Since this is a burns patient, and we had said earlier on the total body surface area was 21%, so you can calculate and come up with that. Then wound dressing and wound care for the burns. dressing with gauze, and then we applied the wound cure ointment on the wounds. We administered the C-collar to stabilize the C-spine and prevent further injuries to the spinal cord. And then we consulted the orthospine team for further management of this patient.
So Connie, briefly, you could then give us your pearls and pitfalls, just a few things we should take home with us in 2 minutes.
Okay, so in 2 minutes, what you should take home is any patient with a history of a fall from a height, think cervical spine. Before you do anything, in your airway, think cervical spine. It will kill them before everything else. For a patient with burns, calculate the total body surface area. You can use the rules of 9 for adults and the rules of 7 for children, and then calculate which amount of fluid they will need using the Parkland formula. The Parkland formula is only useful in the first 24 hours. If you get a patient at the ED after 24 hours, please don't use the Parkland formula. Find any other ways of calculating maintenance fluids, because we are no longer resuscitating this patient. And for the pre-hospital team, if we are going to pick this patient, sometimes we may pick this person right from the scene. We need to be very safe. We need to make sure the current source has been switched off so that we do not be victims as well. So we make sure we turn off, or we ask if the current has been turned off. We ask if the scene is safe for us to approach, and then we approach the patient. All in all, for all emergency care patients, if you approach them in the ABCDA strategy, it is easier for you to figure out what's wrong with the patient. I'll tell you one interesting thing. When I saw he occasionally gets confused with an old man, my first thought, delirium. But here we are. It was an electrical burn with a cervical spine injury. So the history you're given by the person bringing the patient, the EMT team, should not bias you. Look at the patient A, B, C, D, E. You'll be able to figure out what you can do for this patient. For emergency medicine, the diagnosis, the definitive diagnosis is not very important. What is important is how your patient is presenting. How can you take care of those things that can actually kill your patient in less than 30 minutes? Thank you so much for listening to me, and have a good night.
Okay, thank you so much, Doctor. So from that, from the case that we've had, burns, so it was a case of burns. So we're just going to give a brief management of burns, as Dr. Connie had explained earlier on. So in the burns management, usually we have to do the ABCD resuscitation. You look out for your airway, the breathing, circulation, disability, and then exposure. In the airway, you have to look out to be ready to do early intubation if there is any airway compromise. And here, mostly we have to look out for patients who present with maybe inhalational burns, patients who have been burnt within confined spaces, so they are at risk of airway compromise. So you have to be ready to carry out intubation. Then in the breathing, we have to give high flow oxygen, assess for carbon monoxide poisoning in these patients because it's likely to happen, more so those who get burns within houses and enclosed spaces. Then you look out for pneumothorax because some of these patients can get burns and then also get trauma. So you look out for pneumothorax because it can easily kill the patient before you recognize it. Then also acute respiratory distress syndrome, which can present as difficulty in breathing in this patient. So you also look out for it. So in the circulation, you have to do fluid resuscitation according to the Parkland formula. And before you can use the Parkland formula, you have to know your rule of 9 to how to calculate the total body surface area. For adults, you use the rule of 9s. You can look out for it. Then you do your Parkland, which is 4 mils times the kilogram times the total body surface area covered by the bands. So you have to monitor urine output because Burns patients are at risk of developing kidney injury because of the tissue injury that is happening in these patients, rhabdomyolysis, which is happening. So you have to look out for the urine output. You have to insert a catheter and monitor the urine output. As doctor had said earlier on, the normal patients, you do 0.5 mils per kilogram per hour, but in Burns patients, it may be higher. So in your disability, we assess the GCS, neurological status, and then the glucose levels. However, in our patient, we are not able to do the RBS. We didn't have a glucometer with us. So you have to look out for the glucose levels in the patient. Then the exposure, you have to fully expose your patient and calculate the total body surface area the burns are covering. Yes, so you have to also do wound care. Stop burning if it's within like 22 hours, you have to run some cold water over the area of the burn. Then you have to clean, debride the wound, dress the wound with Vaseline gauze. You have to give tetanus prophylaxis because they can easily get tetanus, these patients, because the skin is not protecting them. Then you also have to do an early surgical review for deep or extensive burns. Like for our patient, had really extensive burns, so you have to do a surgical review. It may involve the plastic stem or the ortho. In general, you monitor the patient for at least 24 hours. So also important to manage is pain in these patients. They have a lot of pain because some of the burns are really extensive. So you have to do pharmacological management, and then you also can do non-pharmacological measures to manage the pain. And the pain management, you manage using the WHO pain ladder, where in the step 1, the patients have mild pain, step 2, mild to moderate pain, then step 3, moderate to severe pain. And then that is the WHO ladder, which you follow to manage the pain. You don't just start with the strong painkillers because the patient is in lots of pain. You start, then you keep on progressing to stronger. Then we also have non-pharmacological measures where we need psychological support because these patients they are traumatized, so you need psychological support. Then you need to control anxiety and relax the patients, reassure them, give them reassurance. Then physiotherapy and early rehabilitation, because we know some of these burns can complicate into contractures, they can make the patient lame, so you need to involve physiotherapy as early as possible. Then we need to do adequate wound dressing to keep the wounds clean and free from infection. Next slide. So these are the major complications that we manage to come up generally of burns that can occur. So one of the complications would be wound infection and sepsis. We know these wounds are really extensive. Some of them go really deep, so they are at high risk of getting infected. So that's why you have to keep them clean and prevent sepsis. So they can also complicate with hypovolemic shock. Dr. Kwani had talked about that earlier on because the skin is a protective layer for you from losing water. So if there is damage to the skin, then you're at risk of losing water. So they can present with hypovolemic shock. You have to manage that. That's why you have to give fluids. Then we also have complications of AKI from rhabdomyolysis. This is breakdown of muscles and other tissues in the body. So they can cause AKI. So that is why you have to monitor the urine output. These patients can get hypothermic. That's why we need to cover the patients. You need to keep the patients covered and warm. Then they can get compartment syndrome, as Dr. Connie had talked about it earlier on, so you should look out for it. Inhalational injury, mainly patients who have been burnt with fire, so they can have inhalational injury, which can cause you laryngeal edema, which is very dangerous, so you should look out for that. Contractures and hypertrophic scars. These are the ones that can cause the patients to be lame and cannot move fully some of their limbs. So you should look out for the contractures and correct them early enough before. And then also hypertrophic scars. Some of these burns may never heal completely very well, so they may develop scars. Then multi-organ dysfunction, because this could be as a result of the sepsis or as a result of hypovolemic shock or tissue injury itself. So for a special case in electrical burns, the main complications we are worried about are cardiac arrhythmias, because we know electricity is current and the heart also operates on current. So if there is high voltage, it could cause cardiac arrhythmias in these patients. So you should look out for that. That's why we had to do an ECG. Then we have deep tissue necrosis, mainly muscles, the breakdown of muscles, and that could cause you AKI. We are worried also about renal injury because of the deep tissue injury and rhabdomyolysis. Then they could also cause nerve injuries, which could be peripheral or the central. Could injure the peripheral nerves, could injure the spinal cord. So you should look out for all those. I think, is this our last slide? Oh, okay. Thank you very much.
Thank you so much, Silas, for guiding us through this case beautifully. And I hope that there's been a lot of learning. People have picked so many lessons from the case of today. We are still going to continue taking lessons from this case. This presentation will be shared in the will be uploaded to in YouTube and shared on our website. And please go ahead and interact and learn as much as you can from the case. And thank you, Connie, for giving us the expert opinion that has helped us to contextualize some of the things that were being presented as well. Get to know what to do at every step while taking care of a patient with electrical burns. And there are conditions that are specific for electrical burns that we should be paying attention to, as Silas has highlighted. And we hope that the case has given you insight into how to approach this electrical burns when you get them in the emergency department. And I'd like to thank everyone who has given time in this presentation. This is our wall of fame. It has all the record of everyone who has taken initiative to prepare a case for us, as well as the secretariat that's always behind the scene to ensure that the sessions happen every month. We are very grateful for the time that you always commit to allow for this learning to take place. We shall also be recording a podcast in regards to this case so that we can continue the conversation, and I'm looking forward to that. With those, I wish you a very good evening. Thank you all for calling into today's session. We can continue the interaction on the WhatsApp group. Goodbye.